Hi, everyone. Welcome to the first live webinar of COVID class, a liberal arts exploration, hopefully an explanation too, but at least an exploration of the coronavirus pandemic. I'm Dr. Taylor Newton.
And I'm Dr. Devin Fisher. I wanted to begin with probably something of an odd way to start a webinar series, which is with an apology. We've had a couple of little snafus along the way. Some of you may have gotten a Gmail. If you have a Gmail account, you may have gotten an initial email from me that was in multiple colors. And Dr. Newton, I think if I had known we could do that, I might have tried for red and black instead of the blue and purple that seemed to have gone out. With that kind of stuff, we're just going to ask for your patience because, as I said in an email that I sent to y'all this afternoon, this is the first time that we have ever taught a large course on pandemics during a pandemic, and it's been a learning experience.
Absolutely. And we said that we would learn, right? We would learn right along with the other professors in this class, but we're starting early, our learning process. So just a little bit about what to expect here during this webinar. Our guest speaker, Dr. Kathryn Tinkelenberg, who Dr. Fisher is going to introduce shortly, is going to start us off by speaking for about 10 minutes or so, giving us a little bit of additional information. And then Dr. Fisher and I have some questions for Dr. Tinkelenberg that we will ask. And we would also love for you to please join in with your questions. Below, there is a Q&A button. Please feel free to click on that. I'm going to be paying attention to that throughout the webinar. And you won't be able to see one another's questions in the Q&A, but we will bring them out and offer them to Dr. Tinkelenberg, recognizing that we probably won't get to all of the questions. To respect your time, we're going to end at 8 o'clock. But given that there's probably a lot of interesting and important questions that you'll have that we won't necessarily have the time to get to, please do feel free to continue the conversation on our YouTube channel when we post this video there tomorrow. Dr. Fisher is now going to take it away and introduce Dr. Tinkelenberg.
Yeah, so it's my privilege tonight to introduce Dr. Kathryn Tinkelenberg, who has been a fantastic colleague of mine, I believe for the whole time that I've been here. I can't remember if I think you had started here before I did. Dr. Tinkelenberg has a BS and an MS from The Ohio State University. I've had to be coached by some friends to get the first part of that correct. She has a postmaster's certificate in nursing education as well as a PhD from Duquesne University. She has certifications as a nurse educator from the National League of Nursing and is the director of our MSN program here in Hickory, which has tracks in both education and administration. Her clinical background is primarily in critical care. And although she does not have a background in public health, that is one of her very strong interests in it. And I'll add that Dr. Tinkelenberg brings a particularly strong qualification for us tonight, as she regularly teaches a course on pandemics for our first year students. So please join me in welcoming Dr. Kathryn Tinkelenberg.
Thank you, Devin and Taylor. I am thrilled to be invited to participate. When I got the email, I was like, yes, definitely. So as Dr. Fisher mentioned, I don't have a public health background, so I am not a real epidemiologist or anything like that, but I have a very strong interest in it and have had for several years. A couple of years ago, I managed to convince my school chair to let me teach a class that was in the gen ed curriculum on pandemics, because it's something that my family would tell you I've had a weird fascination with for quite a while. So when this all started back in January, I follow things on Twitter, and I saw Johns Hopkins I'd seen a news story about the cluster of pneumonia in Wuhan, China, and I thought, this sounds familiar, because I've been a nurse long enough to remember when SARS was a huge concern. So I was like, this does bear watching. And then I was looking on Twitter and I saw the map come out from Johns Hopkins. And I started following the map. And I was sitting there one day in my office and I clicked on it and I'm seeing all these little red dots and I'm like, this is about to hit the fan. And forgive my slang there. I was like, this is going to get bad quick. And the next week I actually went into my class and I said, guys, we're going to start following this. We're not going to talk about it right now, but I want you to pay attention to this because I may start bringing aspects of it into class. And so spring, we not only talked about pandemics, but we started living it. So it was very surreal. I actually had a young man come up to me back in February and asked if his family should take a cruise this year. And I said, if I were you, I wouldn't. And they hadn't even really had that. They just had that first cruise ship incident. And I was like, yeah, I wouldn't get on a cruise ship this year. So I've often wondered if he looks back and thinks, did she have a crystal ball or something? But I just thought, this is not going to go good. But so it's been very interesting watching this unfold. So I start my class always asking people my students, I ask them to write, what do they believe about how people get sick and what do they personally do when they get sick? Because part of what we do is explore the behavior that surrounds these pandemics. And I always like to see where they're coming from, knowing that, it shapes our perspective. What we believe about how we get sick and what we need to do to get well drives a huge amount of what happens. So that's kind of how we got to this point. I'm not sure, that's not quite 10 minutes, but.
In that case, we can kind of jump into some questions and answers. And I had to laugh. My in-laws, I probably shouldn't tell on them in this kind of a format, but they were scheduled to go out on a cruise right up until the Saturday before all the cruise ships completely locked down. It's been an interesting couple of months. And I want to start questions from us on the panel here. I do want to encourage our audience, please use the Q&A feature. We would love to get your questions for Dr. Tinkelenberg. And we'll monitor those as they come in. Can't promise that we'll get to all of them, but please do shoot your questions out this way. We would love to have those. Dr. Tinkelenberg, one of the things that I'm finding really distressing right now is a story that a friend of mine, Charlie Day, an employee here at Lenormand, shared on Facebook yesterday. And it was a story from the New York Times, and it listed the top 15 most likely places that we will see flare-ups of COVID-19 over the next month. I believe it was the next month. It had been a couple of weeks. And the Hickory-Lenore area was number 13 on that list. And I'm wondering if you can just reflect on that a little bit both as someone who has experience practicing a nurse, but also as a professor of nursing. What's causing that? What's going on with that? That's not the place that you expect to see a small town like Hickory.
Well, part of it there are a couple of things it has to do with. It has to do with our proximity to other communities that are bigger, like Charlotte. We're not that far from Charlotte, but we're also not terribly far from what is a major outbreak in the state in North Wilkesboro. So we're not far from North Wilkesboro. So it's not too surprising that it has started to travel down this way. Part of it also, I think, has to do with if you go out in our community, you do not see people practicing social distancing unless they're forced to. Like, you have to stand on the X when you're checking out your groceries. You do not see people wearing masks. And so it's really hard. People are not they're not considering it to be a threat to them. And that we start to let our guard down because we were all geared up in March and we were all going to flatten the curve, and we did do that. But now as we start to relax, it stands to reason that sometimes it takes a little longer to spread out into the more rural communities. So it was a little alarming, but the numbers also aren't huge yet either. So
I wonder if you can say a little bit more. The other thing that really surprised me on those New York Times lists was seeing North Wilkesboro on it. And they were not listed as one of the ones likely to see a flare-up. They were listed as one of the ones in crisis mode. So can you say anything more about what has happened there?
It's a meat processing plant. They've had an outbreak at a meat processing plant there. There's also been there was an outbreak another place somewhere in North Carolina, I think down towards Hamlet, in a chicken processing plant. It has to do with how close these people work. They stand shoulder to shoulder on these lines. They are also people who are at a higher risk. For whatever reason, this virus is, attacking people of color, for one thing. And the other thing is poverty always plays a role in these pandemics. And it's the people who are of the, lower socioeconomic, they don't make as much money, they live in poverty, have fewer resources, always bear the brunt of these. And that's why we're seeing it in these meat packing plants. These people are coming from, they're hourly workers, they're coming from an area where maybe it's more densely populated. You have more family members all living together, and the disease is spreading through this particular community. So they're picking it up at work is what's happening. Somebody brings it in, and when you're that densely packed together, it's going to spread. And that's why they've got that in North Wilkesboro. We saw the same thing in the Dakotas earlier, I guess it's been about 3 weeks ago. So it's just part of it's the nature of the work environment that they are in.
There are lots and lots of questions rolling into what you're talking about right now on the Q&A. One related one is from Hani Nassar, who asked, even though the official confirmed cases in Catawba County, it's 175, what do you think the real number is, and what's influencing that?
Well, obviously the real number is probably a little bit higher than that, and I think the real number will grow because they don't know how many people out there are asymptomatic or mildly symptomatic. But it's still not huge yet because they've done some studies where they've gone out. I was reading one today where it was done in San Francisco where they tested an entire census tract. That's been done in a couple of places. It was also done, one of the countries in Europe has done a lot of testing, and it's in less than 10% of the general population. So it's going to continue to spread, but what we don't know is, because you don't know how widespread it is, we don't know how severe it is. So there are more cases out there, I'm sure of that, but it's hard to say how many. I mean, when they say 80% of the people it's mild, it's like, okay, so maybe we're only seeing the 20% who feel sick enough to go be tested.
Building off of that, Amy Cloyd Palmer was wondering about those asymptomatic or less symptomatic people. How are they transmitting the virus at all if they're not coughing and sneezing, the normal routes of transmission that we normally think about?
They're still talking. They still talk. They may sing in a choir. That's happened. They may, we all, it's allergy season. We live in one of the worst places in the country for allergies. So a lot of people may be thinking, oh, it's just their allergies, and maybe it's actually they're one of the people who has a mild form of COVID. So they know that they're still trying to figure out how much it can be spread just through talking. We know about coughing and sneezing because we've known for a long time that's primarily how the flu is spread. But there's still they don't know how much it's spread from touching surfaces. So it's hard to say, but that's one of the reasons they're trying to get people to wear masks, is because if you are asymptomatic but carrying it, if you have a mask on, it keeps those droplets in close to you instead of going way out.
Gotcha. Yeah, that makes sense.
I see a question here in the Q&A that I'm particularly interested in, and it looks like it got cut off just a little bit. So it's from Dan Brown. So Dan Brown, if I misinterpret your question, please send us another one. But it looks like it has some to do with the way in which we have had our understanding of the virus evolve over time. And
yes, definitely.
The direction it was going was how do we develop our understanding of a virus like this in an ever evolving situation without contributing to the sense that there is just massive misinformation?
It takes time to learn about stuff because they really don't know. I mean, there's been a lot of discussion about was China hiding stuff? And the reality is, when you're in the midst of fighting a pandemic, you don't necessarily have a lot of time you do a lot of study and a lot of analysis on the fly. And those sorts of things take time for information to come out. Sometimes it takes a while to start to study these viruses as well once we get through the pandemic. After the SARS epidemic in the early 2000s, they've done some study with it, but the study they've done has been very limited because they've been afraid to play with it too much in the lab because they don't want to accidentally infect lab workers by doing studies. So you have to be really careful when you're conducting those kinds of studies. But it does take a lot of time. I think the important thing is to try to pay attention to various sources of information. There's a lot of good sources out there. Certainly Johns Hopkins, the University of Minnesota, the World Health Organization, the European CDC, our own CDC. You look and you see, well, what are they saying? Because if you're only following one source, there can be a little bit of variability. So I always kind of look and see what's the general consensus. And there's plenty of information out there right now that's available from more scholarly sources like the Journal of the American Medical Association, the New England Journal of Medicine. They're making all of their COVID-19 stuff free and open to the public, and some of it even before it's formally published. So,
building off of that, Dr. Tinkelenberg, I think one of the things that's especially challenging is just how much information there is out there and the way that it conflicts in some ways. So Christopher Negrelli asked about masks and how policy and recommendations surrounding masks have evolved and changed. And other participants are also asking questions about masks. Can you talk a little bit more about what we think are the best practices and why, and how to deal with conflicting information?
Well, early on, a lot of what they were saying is, no, you don't need masks because they need to save the masks for healthcare workers. That's true when you start talking about medical grade masks. We do not all need to be walking around with N95 respirators on. We haven't reached, it's not that kind of a pandemic. But there's been a lot of mixed stuff over the years about masks, but a lot of the studies that look at masks have looked at how much does it protect the person. And we know that cloth masks are not the same thing as an N95 respirator. A cloth mask will provide you with a little bit of protection from you getting the virus, but what they're figuring out is it will prevent you from projecting so many droplets out there. And the reason it's been evolving is because we're starting to figure out that there are probably asymptomatic spreaders out there. So a lot early on, what they were thinking was that this virus was very much like, the virus was very much like some of the previous viruses where you were not really contagious until you were symptomatic. And they now know that to not be true, that you can be totally asymptomatic. You might not ever develop symptoms, but you could still potentially give it to somebody else. So that's why they've now started saying, you know what? It might be a really good idea if we do wear masks, because one of the things to think about is if if you've ever been in an operating room or you've watched that surgery on TV or anything like that, you'll notice everybody in that room is wearing masks. Well, why are they wearing masks? It's not to protect them necessarily, it's to protect the patient. So, because you don't want us coughing and sneezing in somebody's, open abdomen. So they figured out that it won't hurt. It's not going to hurt for us to wear masks. We may be able to cut down on the transmission if we do so.
I think that answers a question that Phil Scott had about the quality of masks and why we aren't asking for even higher quality.
The reality is if we practice social distancing, if we're not all up on each other constantly, we don't necessarily need the N95 respirators. And the other thing becomes from a supply sort of issue. You do want a better quality cloth mask, because that's one of the things they figured out. Back in the 1918 pandemic, they advocated and required people to wear masks, and they figured out the masks weren't particularly helpful. Well, they were too thick was why. So that's why you want to make sure that you have a mask that is thick enough that what they say is, can it pass the candle test? Can you put it on and blow out a candle? Because if you can't blow out a candle with the mask on, it is probably going to keep you from projecting too many droplets. So you want to make sure you have, and the bandanas, double folded will do that. It's hard to blow out a bandana or blow out a candle through a good quality bandana. Or you can do what I've been making masks.
Can we see your handiwork now that you've shown? I have mine here too. This is from my mom.
Well, this one doesn't have the elastic on it yet, but it's just sitting here on my dining room table. So, but yeah, I've been making masks for myself and for my family so that they will wear them when they go out in public.
Very cool. I have another question here from Phil Scott, and I imagine that Dr. Grimm next week is going to spend some time talking about vaccinations, but from an epidemiological perspective, he's wondering, considering that flu shots are not universally taken advantage of, so do you think that a COVID vaccination will spur more of the population to buy into the vaccination program for public health? And then if it's not high enough, do you think we're going to have to wait for herd immunity to really put a stop to this?
I think part of that depends on how things get before the vaccine actually becomes available. So if somebody knows somebody who's had COVID-19 or has, maybe even lost a family member to it, they might be more likely to be vaccinated. But there are other people that, obviously we don't have a lot of people who get vaccinated for the flu every year. But when you stop and talk about COVID-19 is, in terms of, when you compare the number of deaths that you've had from COVID-19 to the number of deaths from flu, it's far greater. We've had over 800 people just since January die of COVID-19. That's more than what we've had die from the flu in the last 3 years in the state of North Carolina. So what will help is there will probably be people who will be mandated to have vaccines. Your healthcare workers, their employer will probably require it of them. Most hospitals now require their staff to be vaccinated for the flu. So they will probably require the healthcare workers to be vaccinated for COVID-19. So I think it'll be mixed, and it may take a while to get that herd immunity, but it'll take a long while to get that herd immunity without more people being vaccinated.
Dr. Tinkelenberg, if I can jump in here with a question that seems to me very much related to this, and it comes from, I believe I saw Drea Mora asks this question. And it's a really interesting connection to the material that you presented in your lecture for us, and it's related to the tension between sharing information and financial profit. So do you know anything about the companies that are developing or working to develop vaccinations? How closely do they work together to share information? Do they have financial incentives to keep things secret?
Well, there's always an incentive to be the first for something. I mean, I'm not a business person, so I'm not as strong up on that, but there's always that incentive to be the first. Now, having said that, vaccinations typically are not huge moneymakers. So there may be a rush to be the first to get it and to manufacture it, but I'm sure because of the number of doses they're talking about needing, at least early on, I would think they will probably share some of that information, but I can't say that I have personal knowledge of that.
And that may be something that we can talk about in week 4, maybe, when we have Dr. Tunai Oguz here to talk with us about the economics of the pandemic. I see several people who are interested in knowing a little bit more about what do we do as this virus mutates? And actually, my own reading tells me that that's a legitimate question too. How much is the virus mutating? How is this compared to other viruses? And what will that do in terms of the challenge of creating a vaccination?
It is mutating, but to this point, and I think Dr. Grimm probably can explain that better than I can, but from what I've read, it's not mutated significantly to this point to make making a vaccine difficult for it or impossible for it. And the reason I say that is there are some, like for example, they've been working on a vaccine for HIV for 30 years and they still don't have one. But once they put their mind to it, they were able to pretty quickly come up with one for Ebola in the overall realm of things. When you consider that Ebola was first identified in the 1970s, they didn't really do a whole lot about it because honestly, there wasn't a whole lot of money in it. It didn't seem to be perceived to be a huge problem until 2014 when they had the Ebola epidemic that affected several countries in Africa and killed 11,000 people. Then it became a big problem. And within a couple of years, they were able to have a vaccine that's pretty effective. So the thing is, if it does start mutating, if they can get a vaccine that is effective, at least initially, they might be able to continue to tinker with it, just like they do the flu. I don't know that for sure. I'm not a microbiologist, but Dr. Grimm could probably talk better about that next week.
Dr. Tinkelenberg, I'm seeing a couple of questions from people who are interested in your own personal experience as someone who has an interest and an expertise in this area, watching it unfold. Someone wants to hear more about, I think it was Dan Brown wants to hear more about your aha moment of seeing the dots on the map spread. And then Sarah Llewellyn wants to know, do you think it's possible that the virus was here before that aha moment, before the dots started to spread?
I think it's possible. I mean, when I had that aha moment, I'd probably been watching the map for a week, and you just start to see more dots showing up as it starts to spread out across China. And it's like, this is spreading. And it's just kind of like, China is a big country geographically and has, huge numbers of people. And it's like, yeah, this is gonna spread. Even at that moment, though, I don't think I really expected that it was going to take the turn that it did. I think maybe because it's a little hard to wrap my head around, yeah, I'm going to be staying at home and working remotely for 6 weeks or longer. But it just was like one of those things where it was like, oh, wow, okay, I'm not really sure what to think about this. But then I started doing the little things that I usually do. I started, putting in a few more cans of soup and things like that. I mean, not really going full on, like, I think Bill Gates said he had a year's worth of food in his basement. I didn't quite go that far. But I started thinking about it, but at the same time, you don't want to say anything because it's like people will think you're weird or people will think that you're crazy. I mean, I think it was back in late February, I emailed the president of the university and the provost and the dean of students and said, yeah, what are we going to do about COVID-19? Are y'all at least talking about this? I mean, I'd wanted to send that email for a couple of weeks, but I thought, oh, they're going to think I'm nuts. So it's one of those things where it's like you don't want to be an alarmist, but at the same time, you want people to start to think about it. I mean, I have 3 adult children who, 2 of them live here in North Carolina and 1 lives in California. And so I'm tracking that very closely, and I'm tracking, what's going on. Some of the first cases in North Carolina were showing up in the Raleigh-Durham area. So that's where one of my children lives. And so it's kind of like, okay, you want to say something to them, but you don't want to alarm them. Because you don't really, it's not like I have a crystal ball and know what's going to happen. So it's just kind of like, ooh. It's been rather surreal. And I would stand up in front of my class every week and say, we would talk a little bit about it. We'd link it to whatever we were talking about that week. And I'd say, guys, I know this has got to be surreal to be living what we're talking about. And we like to think that our behavior has changed since the Black Death of the 1300s. And maybe it has to a certain extent because we're not burning people alive at the stake and we're not going through the streets flagellating ourselves, but we're still engaging in some similar behavior. There has still been, and you'll probably get into it in other classes, where there's still been prejudice, and there's still been people who they're not flagellating, but they're protesting. And so you sit there and you go, wow, have we learned anything in 700 years? I'm not sure what the answer to that is.
I think it's probably one that we're going to return to with Dr. Delbert when we're talking about polarization, as well as Dr.
Probably
McCall about historical approaches.
Yeah, probably so. But I mean, that's something I've been thinking about as we go through this, is looking back on it going, wow. And watching how the CDC has behaved through this is so reminiscent of how they behaved in the early days of HIV. So that's been really strange to watch.
Dr. Tinkelenberg, I'm seeing several questions here. I'm trying to find the thread between them. It's there, and I think it has a lot to do with touching more on your interest in public health, related to the things that we know about what we should be doing as we move back towards normal. I don't know that we're ever going to get back to normal, but there's a question about, for instance, what do we know about air conditioning and air circulation systems in buildings and what potential that has? There are a couple of questions here about, are we opening up too soon? And I wonder if we can just turn our attention for a few minutes to that kind of public health perspective on this, knowing that your doctoral work is in nursing, but you do have more knowledge there certainly than I do.
I mean, one of the things to think about with regards to air conditioning systems and stuff like that, with ventilation, when you talk about how connected are ventilation systems, it really kind of depends on how closely connected they are. I'm not an environmental scientist, but obviously something happened on those cruise ships, and you have to wonder, did it travel through the ventilation system, or was it more because the crew was going room to room delivering stuff? Were they carrying the virus through them? And I honestly hope that somebody is combing through those cruise ships and studying it very carefully to try to answer some of those questions. At this point, because it's not considered to be what we call airborne in terms of disease transmission, like for example, tuberculosis is known to be airborne. Airborne means it will travel farther through the air than droplet does. We know that SARS and the flu and viruses like that are considered to be droplet, where they're not going to spread through the air, 45 feet typically. It's not saying they can't. If somebody really, coughs or sneezes really powerfully, perhaps, but just as a matter of routine, because like with TB, when we isolate TB patients, we put them in areas that have certain levels of filtration. So I don't think that they feel that that is necessary at this point, but I'm not 100% sure that they know everything about this virus, but that's not going to be a common way that it is spread, that they're aware of. That could always change. But one of the things that you do have to think about is when we start talking about environmental conditions of viruses, and Dr. Grimm may talk about this, is viruses like this one, like the temperature that we typically keep it inside. It's an ideal temperature for them. So by having our indoor temperature being at 68 degrees, that's an ideal temperature for the virus. At least they think, from the studies they've done with the original SARS virus from the early 2000s.
And related to continue the line of questioning about the public health side of things, there are a couple of questions that have popped up here that have to do with normalizing some of the behaviors that are going to help stop the spread of this disease. So the mask wearing, there was a question about how to get younger people. I mean, I have a 16-year-old son. He has said to me a couple of times, well, even if I get it, it's not going to be that big of a deal for me.
Maybe not.
Well, that's what I tell him. But you know, sometimes what it's like trying to tell something to a 16-year-old. But what do you think? What do you think it's going to take for us as a culture to shift the way that we think?
Time.
So that instead of
I think I think it may take a little bit of time. I think a lot of times some change that comes about is incremental. That it takes a little bit of time to get people to buy into it and to normalize it. I mean, the whole idea of washing our hands, we should be doing that anyway. We really should be. We've been taught that. They teach them that in kindergarten. I mean, so we know we should be washing our hands. It's just a matter of trying to do that. The standing farther apart, I think that's hard for us because as humans, we want to get close to one another. Although, I mean, there are cultures where you don't get that close and there are cultures where you get super close. So it may take a little bit of time. The whole idea of wearing masks, that can be a shift in culture too. There are places in the world where it is perfectly normal to wear a mask, where they wear them in certain places. I mean, and if we just start to think about it, you know, when you get in the car, what's one of the first things you do? You put on your seatbelt. Well, maybe before you step on the subway, you put on your mask. I mean, so I think it gets to be thinking along those lines, but what we need is consistent, constant messaging from a public health standpoint. And that's a little hard to get right now because it's still so early in all of this that what we know about it keeps changing. You know, there's been discussion about, can it be aerosolized from flushing the toilet? You know, things like that we don't know yet. Because we've only known of this virus since January.
I have these moments of panic intermittently. Most of the time it's fine, but every now and then it comes up. Toilet aerosols. Okay. Dr. Tinkelenberg, Svetlana Henderson was wondering about an approach being taken in Israel, a controlled avalanche approach to building herd immunity. I believe Sweden followed a similar model in pursuing herd immunity, but the one that Svetlana is describing, she says the population is divided into high and low risk groups. The low risk group is voluntarily exposed to the virus and the high risk group is protected. What do you think about an approach like that?
I would never voluntarily expose anyone intentionally to any sort of thing that's going to make them sick, because just because you deem somebody to be low risk, you cannot know all of the factors that play into this. So I would never do that. It's like those people who have chickenpox parties to expose their children.
I had one of those when I was a kid. That's how I got chickenpox. It was awful.
I mean, just because you don't really, what we know about this virus keeps changing. We think it's not serious in children, and here we are with these COVID syndrome. I'm not sure how many cases there are. It's still rare, but where these children are getting incredibly sick 6 weeks after they may have been exposed to the virus. I mean, I'm not a fan of ever exposing anybody to something that might make them sick, because people can have a hyperimmune response to something, and they do think that may be what goes on in some people, in these people who were presumed to be healthy get COVID-19 and die. They think in some cases it may be how their immune system responded to it. I mean, so I'm not a fan. But again, I'm also a fan of, if there's a vaccine for it, I'm going to take it. So I'm not a fan of trying to promote herd immunity. We also don't know what it takes to get to that, because one of the things we know about these diseases, and we have no idea what the number is for things like SARS, is it takes a certain number of people to support the sustained spread of it. We don't know what that is. We know that, like, for example, measles takes several thousand people in order to sustain an epidemic of it. You'll have an outbreak, but it dies off. But in order to have a sustained continuation of it, you have to have a certain number of people. We have no idea what that is for this virus.
I think one of the challenges of all this is kind of balancing that uncertainty with the very real struggles that people are having, that are particularly influencing more vulnerable populations, as you had pointed out before. So Gabe Korn, he asks, he works in a food service industry in South Carolina, and the Department of Health there requires them to wear gloves when touching food, but no other changes like requiring masks. So do you think that's enough for preventative measures? Or he uses the phrase blowing it out of proportion, which I've heard from a lot of different places. Can you help us to gain some perspective here?
Well, I mean, one of the things about what you have to talk about with wearing gloves, when you're talking about handling food, part of the function of gloves when handling food is part of it's to protect the worker, and then part of it is to protect the other people. Because if I'm handling raw meat, there's going to probably be microorganisms in that, and I should not be handling that with my bare hands. If I'm working food service continuously in my kitchen, obviously I'm going to turn right around and wash my hands. But it's hard the idea about masks has to do with cutting down the transmission directly to people. They don't have any idea that it can be transmitted on food or through food preparation. No, they haven't necessarily said, oh, absolutely not, but they don't think that's a way that it's transmitted unless somebody sneezes on your salad and then serves it to you. You're probably not going to get it that way. It has to do more with when they're requiring the food service workers to wear a mask, it's more because they're coming up to you and getting within 6 feet of you to bring you your food, is what that's about.
Good to know. Thank you. We've had several questions about the sensitivity and specificity of antibody tests. Is it possible to take these tests and get a positive result even though you don't have it, and vice versa? And how much can we trust these tests if they're really informing the public health decisions that we're making as a nation?
I think in terms of the actual testing for the virus, they've got that down pretty good. They do have some reliable tests to test whether or not you currently have the virus. The antibody testing, I think the jury's still out on that at this point in time. I don't know that they have developed, it's going to depend on where you get the test from, because the FDA has allowed them to, they've issued emergency use sort of things and are allowing a lot of people, not a lot, but are allowing companies to put these tests out there, because part of it is, I think, studying it while, using it, but they're finding out that they may not be as reliable. It takes time to develop those sorts of things. So if I got an antibody test that said I didn't have it, is it a false negative? I don't know what the exact percentages are, because I'm not sure they've reported it. It's not like they've said for this test it's accurate this amount of time. I don't know the answers to that.
I wonder if you would reflect a little bit. I know this is on my mind. We both serve on the task force that's looking at how do we reopen a university in the fall. We've had a number of questions come through here about opening schools. And I think the underlying question about that, and this is asking you to do something that you can't do, but you've probably got better qualifications to take a guess at least than some of the rest of us. And that's to think about what might we expect as far as this virus developing. Would you anticipate a big second wave of this? Would you expect to see the second wave happen in the next few weeks as we start reopening? Or is this likely to be like the flu that is a seasonal thing until we develop a vaccination for it? And we want you to look into your crystal ball and tell us all the answers here.
It's really hard to know the answer to that. Without a vaccine, they do think it'll be around for a while. Because this virus, we've only how long has it been around for sure? Who knows? It could have been around a little longer than what we think. Obviously, I think they have figured out that they have cases that they can test positive for it in China as far back as November. So we know that it's been around for a while. How long, who knows? Probably not terribly long, because respiratory viruses typically do spread pretty quickly. So has it been around for years? Probably not. Has it been around for months? Probably. With regards to does it become seasonal, that's something I know that they're afraid may happen until we develop a vaccine. I think what we look to see what's going to happen is what is happening in other countries as they reopen. And as we look towards, we can look to see if we think it may behave like flu. They always watch the southern hemisphere for predictions of what our flu season might be like. So the southern hemisphere is heading into fall and into winter. So what's going to happen there as it gets colder there? Is the virus going to resurge? I mean, I'll be interested to see what happens in Australia and parts of China again. And it's hard to know. I mean, I do think it's around for a while until we know more about it. In terms of reopening, obviously we cannot all stay at home forever. That's not going to work. But
that actually gets at a question that is one that's been kind of haunting me. Everything in me, everything that I value tells me I can't think of human lives in terms of cost-benefit analysis when we're looking at this, and yet there's no other way to do it. And the question here is there a risk and reward number that should guide our return to normalcy? That's coming from John Hall a few minutes ago. And this will be something we explore all summer. This is going to be something that ties things together, but I do want to give you a chance as a healthcare professional to weigh in on that.
Obviously, as a healthcare professional, what we look at this point, we go back to that idea of flattening the curve. We don't want to see a sudden resurgence where we have more people who are sick than our healthcare system can handle. We don't want to have that. Obviously, in a perfect world, we don't want anybody to be sick. But what we don't want to have happening is we we don't want people getting sick and dying because we don't have a bed for them. So that's, from a healthcare perspective, that's what I think we have to look at is, and it may not be as we reopen. I think that's the other thing we have to start to think about this, is think about this as a little bit differently, and maybe not thinking about it on so much of a global national level where we might have to be thinking about, this area is having an outbreak of it. Maybe we do need to close schools for a little bit and people work from home for a little bit, but it might not mean everybody in the whole state or everybody in the whole country has to do that. I know they needed to lock down the country because of how quickly this was spreading. It was a novel virus that we had never seen before. So that means that because nobody had ever had it, we could see a whole lot more. Well, as time goes on, we will probably we'll have more people who will have had it. So therefore, the virus has less susceptible hosts, at least for a period of time. They don't know how long, if you've had it, they don't know how long you're immune from it again. But you are, at least for the short term, they believe to be immune from it, at least in the short term.
We're getting close to the 8 o'clock hour, and we are going to stick to a very strict, that's when we end, which means there's some questions out there that we haven't gotten to. But I think Dr. Newton and I as panelists have one more question for you, but there's one here from Lee that probably leads into it pretty well. And Lee asks, this connects back to the materials from this week that were in the Canvas site, particularly the Bill Gates video. Once we get a handle on this pandemic, what do we need to do to prepare for the next thing?
Fund public health better. Well, I mean, that's been something that's been a theme across this, is in this country in particular, public health is not adequately funded. So they were not, that's one of the reasons the CDC was not as prepared. Everybody thinks the CDC is super prepared for everything all the time. And the reality is that they have limits that are related to, like everybody else, to budget. So we do need to do a better job of funding public health better so that they can respond quicker and in a more seamless fashion. I mean, I think obviously the local health departments in a lot of places have done fantastic jobs, but you have to have your local health departments and your state health departments and everybody communicating and working together. So I do think to be better prepared, we have to pay more attention, and that means put our money where our mouth is.
Excellent.
Dr. Fisher, I did have one additional question before our final one for Dr. Tinkelenberg. Hoping to get it in under the wire here. You are a professor of nursing, Dr. Tinkelenberg, so I wondered if you could answer this question from that particular area of your expertise. We've learned in recent weeks that people of color seem to be especially vulnerable to the virus, with disproportionate rates of infection and complications, including death. Can you help us to understand why?
It comes back to something that we call the social determinants of health, where how healthy you are is based upon a lot of times where you live and what your access to those things that promote a healthy lifestyle is. So those things cover everything from access to a grocery store to buy healthy food to your access to primary care and other forms of health care. So we know that in this country, disproportionately people of color are less likely to have good access to those things. In some of the areas where we've seen it, for example, in parts of Chicago and in Detroit and parts of Louisiana, where they've had huge numbers of cases in the populations of people of color, it's been in areas where they did not have those things. Like there are parts of Chicago where there might be one primary care provider for, a larger number of people than what is considered average. So because of those social determinants of health and the lack of access, they are much more likely to have the comorbidities that they know are linked to this. They're more likely to have heart disease, hypertension, and the other thing that emerges particularly in the African American population, kidney disease. So, and also diabetes. I mean, so those are some things that are really, that's part of what is driving it, is those comorbidities along with those social determinants of health. Because one of the things we know about our immune system is it is dependent upon our nutrition. It's one of the things that's dependent upon. You need to have a adequately balanced, nutritious diet in order to promote your immune system to be as healthy as possible. So some of these people who are living in food deserts may not be, their nutrition may not be as good as somebody else's, and that certainly contributes to how healthy their immune system is.
Dr. Tinkelenberg, as a final question for you, what would be the one thing that you might recommend to each of us? I think many of us are feeling kind of helpless in the face of this. Like, I'm stuck here at home, I'm doing that, but otherwise, what is the one most important thing that I can do, or that Dr. Newton can do, or that any of our participants could do to help at this point?
You mean beyond wash your hands?
Yeah, let's go beyond that one.
Go beyond that one. I think it's important to remember that this is temporary. It's hard to see that right now. It's almost like a forest and trees moment where you're in the midst of it. It's really hard to see. But the thing about it is human beings have been surviving pandemics and epidemics and outbreaks for thousands of years. We will come out of this. And from studying these, I know there's always some sort of change that comes about from major pandemics that, and Dr. McComb may speak to this, they think that women got the right to vote as a result of the flu pandemic in 1918. So, there's changes that may come out of this that hopefully we'll learn something and make the world a better place. So you just have to remember that, tomorrow's another day. So one step closer to being through it.
It's hopeful.
Thank you. Yes. Thank you for that answer. I would love for us all to be able to give you a loud round of applause, but that would mean that we would be sitting together in a room somewhere, and I think that's probably not what we want to be doing. But please know that the applause is there. For our participants, thank you for joining us on this first round. I know that it wasn't the most smooth sailing getting here. I hope you found this to be a helpful and useful thing. We will be sending an email on Sunday when content for next week, which will be led by Dr. Dan Grimm, is up. And I think we will probably include in that a brief survey of your experience of the webinar, because frankly, we are still learning very much how to do this. I think the largest class that I've ever taught before this one might have been 30. So there's some scaling there, and we need your input to know how to do it better. So thank you for being...
How big it is, Dr. Fisher? I don't think we have. It's 800.
Yes, we are at 800 participants in the class, and I don't know if our participants can see, but we've been hovering between 170 and 180 on the webinar tonight. So we are grateful for your presence. Each one of you is why we do what we do. So thank you, and we will hope to see you next week. And I'm going to end our webinar now.
Bye, everyone.
Bye.